Thank you, Catherine. Very exciting to be here. So I think we're going to just start with our first panel. So I'm going to be introducing all four panelists, and in a moment I'll have them come down and join me here and take a seat. But just to give you an outline of what the next hour is going to look like, it's going to start 15 minutes or so introductions of each of the panelists. About their research and about where they think the field is headed or where it should be headed. And then for about maybe 15 minutes or so of question and answer that's moderated between the panelists. I'll be asking some questions and trying to get some, hopefully some meaningful insight. And then finally, the last 25, 30 minutes, we'd like to open up the discussion to the audience. And we have microphones at each wing, so don't be shy. And we can have a great discussion. So with that, I'd like to invite the panelists to join me.
I think Dr. Boot's still in transit. His flight was late. So Dr. Engel, Ms. Engel is going to
That is
split.
clutch.
We'll get Dr. Boot at the next. Thank you very
Well
much.
done. Thank you. That's good. All right. So I'm going to just start with a very brief introduction from left to right, and then each of the panelists will just give a brief 5-minute further introduction. So first, we have Elizabeth Engel, who's the Chief Strategy Officer of UC Health at the University of California Office of the President. Next to her is Dr. Catherine Kahn, who's a professor of medicine at the Division of General Internal Medicine and Health Services Research here at UCLA, and she is also a senior RAND scientist. To my right is Dr. Cheryl Damberg, Distinguished Chair in Healthcare Payment Policy and Senior Principal Investigator at the RAND Corporation. I'm fortunate to call one of my primary mentors. And then to her right is Dr. Daniela Meeker, an Assistant Professor of Preventive Medicine and the Director of the Clinical Research Informatics at the Keck School of Medicine at USC. So an all-star cast, very excited. And so why don't we start with Dr. Engel, if you'd like to start with your comments. You want to have Dr. Engel as the last one? Okay. Maybe we'll have you go last.
Sorry.
Why don't we start on the right?
No problem.
Dr. Meeker. Go for it.
I'll try to keep everything brief because I'm sort of the least among all of these panelists, including my mentors, Cheryl. My background is in neuroscience and AI, and then I did a postdoc at RAND in health economics, and I've been trying to marry all of these disciplines for the past several years. And one of the areas that I've worked on quite a bit is measurement, and on several projects with Cheryl. And I have also been working on trying to change physician decision-making, leveraging information to inform the way that we're evaluating policy and developing policy. And some of the work that we've been doing as part of that is collaborating with people at UCLA and the business school here, to apply principles of behavioral economics and social psychology to influence clinical decision-making towards value-based care using nudges. And I think that the other areas of behavioral economics that are quite interesting for this particular discipline is trying to leverage the understanding of how habits are formed, because value-based care is really a change in habits. Our health systems have been developed around habits of fee-for-service, and changing that is a cultural change as well as something that requires a completely different perspective on how people's defaults behaviors are managed. I think when Atul gets here, maybe he'll talk a little bit more about the role that precision medicine might play in the future of value-based care. But my opinion about that, and I think that the jury is still out, is that we have to be thinking also about precision decision-making and information economics, because of the plot that Steve showed, you see that there's an enormous amount of information, but all of it isn't necessarily valuable or relevant for decision making. And we have to curate that and manage that process in a way that does leverage all of the information that we have at our disposal in order to conserve the resources that are available. Finally, I think that the kinds of enormous volumes of information that we're pointed to can help us inform value-based decision making. But there is a balance between understanding how the outcomes that we are seeking, and as Catherine also pointed out, there's outcomes that are at the patient level, at the system level, and somewhere in between. How those are actually going to be informed by these enormous volumes of data and our experience in that. And I will leave it to Cheryl to talk more about the overall history of what she's been working on. Go for it.
All right. I just want to say thanks to Catherine for inviting me to participate. I'm looking around the room and I see many people that I've already collaborated with and have long-standing relationships with, but I also see a lot of new faces, and I'm hoping this will, in fact, create new opportunities for working relationships. And I'm just going to put in a plug. I know through some of the work that I'm doing with John and Yusuke, who I saw, there you are, I run a very large center grant that has access to a lot of data. And that's something that researchers are also always looking for. And so if you have interesting questions that you want to think about addressing related to health systems and how they perform, come see me. We were asked to talk about the kinds of things we've been working on and what we see as some of the areas needing further work. And the work that I do, I'm very much an applied person. I have moved in and out of research positions, worked in government, worked for nonprofits that have been involved in measuring the performance of hospitals, physician organizations, and health systems. And the work that I do, I try to always do this with an eye toward how this is going to be applied and what some of the potential consequences are going to be, both intended and unintended. So one of the areas that I've worked in is how to measure quality, efficiency, and low-value care. And as Daniela mentioned, we did some work when Choosing Wisely kind of first emerged on the scene. And thanks to a lot of the work that Daniela did, really understanding how electronic health record systems worked, the type of data they capture. What we were trying to illustrate is, while these Choosing Wisely recommendations were sort of concepts, they weren't actual performance measures, the ability to translate those into measures that can be operationalized faced many challenges. Several of them included not having the right data elements in the electronic health record, but also what I would call the lack of clear definitions to be able to operationalize these concepts. So if some type of next step required knowing if somebody's symptoms were worsening, what defines that? I think that there are many challenges out there to being able to measure low-value care, and this area of measurement and trying to understand where are these areas of low-value care, and then how to be able to measure them in ways that don't place undue burdens on frontline physicians as well as systems to be able to capture that information and provide that information back for decision making. The other area that I've done some work in over the past couple of years using data on performance in California is trying to think hard about what does it mean to measure value. Catherine had on her first slide that there's really no consensus on what it means to measure value. How do you do that both operationally and so we did a project where we took data on performance as well as total cost of care and looked at the relative efficiency with which physician organizations in the state of California were producing quality. And that was pretty interesting in that you saw a wide range of total spending to produce quality. And while you needed a certain amount of spending to generate what I would call a minimum threshold of quality performance, the organizations that were at the top end of the quality performance distribution had huge variation in their total spend per member per year, illustrating that there are a fair amount of inefficiencies in how we deliver care and also diminishing returns on our spend on quality. The other area that I've done a lot of work in is examining these alternative payment models, whether it's pay for performance, pay for value, bundled payments. And in particular, my approach is really mixed methods. So while I try to understand, what the quantitative data is telling us in terms of did we get better quality, did we get lower cost at the end of these interventions, my work has really been focused on going inside of these organizations and trying to understand what actions providers are taking in response to these programs, both desired and undesired. And as we think about the low-value care piece of this work, one of the things that I queried, so there's about 200 physician organizations in the state of California, and we pulled a random sample of 40 of them statewide. And in my interviews with them, I asked them about what they were doing to reduce low-value care, the extent to which they were measuring appropriateness of care, and hands down, virtually no one was working in this space. Their focus was primarily on reducing hospitalizations, readmissions, keeping people out of hospitals. And in how they think about low-value care, they know it's an issue, but they're relying pretty heavily on utilization review. And that just really illustrated for me that there's a huge amount of work to be done in this space, despite the fact that, Choosing Wisely had been on the street for a number of years. And I think the other thing, we've been inside of health systems recently asking them what they are doing around both delivering better, quality care, recommended care, as well as low-value care. And in particular, as Daniela noted, use of behavioral nudges. And most organizations have really not cracked that nut in terms of different ways of incentivizing or creating structural supports for providers to both deliver the right care but try to stay away from delivering low-value care. I know we're probably short on time, but sort of three things that I would call out in terms of areas that I think we need to be focused on is really trying to move toward understanding why physicians are delivering low-value care. We've done some initial work to characterize who is and who isn't delivering low-value care, but we don't really understand why it's happening. The second thing is how to get to the change we desire. And I think we all know that different organizations have used a variety of techniques, whether it's coaching, education, financial incentives, and those things are sort of working at the margin, but they're not driving the kind of wholesale change that we want. And I think we have to think harder about designing systems and looking at the effect of changes to, these structural components that support the practice of medicine and what the effects are. I spoke with a physician organization recently in California that had been applying a tool called Agile MD. I don't know if folks are familiar with that tool, but it was really interesting how they had streamlined the patient encounter in terms of the choices physicians or the decision tree that physicians were going through, and making it very easy to either order tests or create defaults to prevent them from ordering tests that would be considered low-value care. And then lastly, I think we have to invest in additional work around how we measure performance in the system, both quality and getting to a better set of measures that are more nuanced and take into account patient preferences. And then lastly, better ways to measure low-value care and value overall. So thank you.
Thanks, Cheryl. I'm going to invite Catherine up here. Go for it.
Thanks. I like to see everybody, and I can't see everybody this half from sitting down there, so I wanted to come up here. I wanted to start by thanking Dr. Australian and Dr. Dubinet and Dr. Sarkisian and Dr. Mafi for motivating this really important meeting. I've been working in the field of quality and value and how do we improve patient care for 35 years. And I've been doing it at the interface between clinical practice and research. And one of the things that all four of us, I think, today were asked to talk in our 5 minutes that were allocated here in the beginning, 2 topics. And one is, what is our research about? Why do we do it? And how have we done it? And then the other half is, what's important about the interface between the research that we do and improving value. And so I know I probably have 4.5 minutes now to try to tackle that, but I will. And I think it was actually very clever for us each to be given only such few minutes, because I think the idea is that following our very brief presentations, there'll be a discussion amongst the panelists, but also with the audience. And I think that's the really important purpose of our session today, is that this really is an extraordinary set of people, both clinicians, administrators, researchers, and as people have said, from many different venues. And this is a great opportunity for us to get together, to do science, to think about clinical care, and to build collaborations. So very briefly, summary of my 38 years of research and clinical care. So I actually, importantly, given the nature of today's meeting, I started my work studying the appropriateness of medical care. And when I started that work, I actually came here to Los Angeles to work with Bob Brook, and it was a really great opportunity starting to think about appropriateness, which was in the context of realizing in the early 1980s that there was substantial variation in utilization of services. And the question was why, and might there be any way to understand appropriate versus inappropriate care? What we did is the most important thing we did in a way that's relevant to what we're talking about now is we tried to build some kind of collaboration. And what we did is we built collaboration with many experts around the nation to try to think about what does appropriateness mean. And we did that not just conceptually and not just from a science point of view. When I say we did it in a multidisciplinary way, we also talked about it in terms of the mathematics of thinking about what's appropriate and how to think about if there's 100 people or 1,000 people who have the same clinical condition, and some of them get an intervention and some don't, we defined appropriate as the situation where those who got the procedure, those who received the procedure, had a better outcome than those who didn't. And that's how we came up with the definition of appropriateness. And then we went to the literature, and we spent about a year thinking about, for carotid endarterectomy, for coronary angiography, and for the procedure that I led the study of, which was diagnostic esophagogastroduodenoscopy, EGD. What is the appropriateness of these procedures based on what's in the scientific literature? We recognized the literature had a lot to offer, but it was also very limited, and it's not really that different than 35 years ago as compared to what it looks like now. But again, back to what I think was really one of the most important things we did in those days is we went, after doing the literature review, we didn't stop then. We then went to the clinical leaders around the country in each of those areas. We did that both through snowballing of our personal connections, but we also did it by working with the national organizations relevant to each of those disciplines. And we asked them to nominate experts who might be willing to think about these topics. And then we pulled these people together to both work with us on science and work with us about decision making. So we can talk more about that through the day and the methods that went well and didn't went well. But one reason I think I was also asked, all of us were asked to talk about research, is to provide a model for how, in the context of clinical care and clinical thinking, do we do research. And so what we did for those clinical content areas, what we did is we ran a number of panels based on the literature such that experts nationally rated the appropriateness of conditions. What the clinical leads in these areas needed to do was to decide how would one even think about appropriateness for these conditions. My job working on endoscopy was to identify the fact that there were 1,069 unique potential reasons for diagnostic endoscopy, even in 1983. And then, given my compulsive clinical nature, we had to multiply it by 3 because each of these, when we thought about these cohorts of people who might have one of those indications, that person might have mild comorbidity, moderate comorbidity, or severe comorbidity. So based on, or with all of our clinical experts who came together from across the country and representing different specialty organizations, they rated the appropriateness, again, based on the literature, but also based on their understanding from their clinical practices of how good the literature was and how well the literature matched what really happens at the clinical bedside. So after we got these ratings, we fed them back to these clinical experts, and then we said to them, well, what do you think about the ratings? And there was some agreement there, and there was some disagreement. So the next thing we did, something that I hope will come out of today's meetings, is we got the people together in a room, these experts nationally, and we said, let's talk about what you think are the reasons for disagreement among this set of experts. Why is this happening? Is this about payment? Is this about fear of malpractice? Is this about what Cheryl was talking about, that is the idea that we haven't precisely, or the literature hasn't precisely defined what we mean by dyspepsia, or what do we mean by upper or indeterminate source of bleeding for GI bleeding. And so we talked about this for days and days and days. We then had these experts go back and re-rate again, and then the fun started. Then we said, okay, we have to have a valid way to understand in the real practice setting, what is the relationship between these appropriate ratings or appropriateness ratings and what's really happening. So we found a nationally representative cohort of patients who had these tests. We worked out the political arrangements to have permission to get medical records from each of these settings. We thought, because we had a clinical foundation here, that if we just looked at the endoscopist's record, we wouldn't really be getting the whole story, because endoscopists they do the procedure on the people who were referred to them. So we needed to look at the medical records of the referring clinician. And sometimes that was inpatient and sometimes it was outpatient. And then we had to look at the medical records of inpatient docs. And then we had to look at the records of the endoscopists. And then we needed to study what did the imaging results show and what did the scope results show. And then is there pathology. And we put all of that together. And probably the most interesting part is we then published what is the clinical epidemiology of the use of this procedure in the nation. And then we said, is this a valid measurement system? And that's just a model for something that I hope we can work more on today. So I might have 2 more minutes left, is that right? So I just wanted, I can't see, 1? Okay, so just a little bit more about my research. So that was really about a foundational set of work, and I was very fortunate to work with Mark Chassin, Bob Rook, Jackie Kosakoff, and Ed Park on that work. But a lot of my work since that time has been on the same subject of bringing together clinical practice, clinical epidemiology, and the science of measurement to try to understand how we can improve patient and population health. And a particular focus of my work over the years has been how do different health policies impact what happens to patients and outcomes. Another task I think I was given in this little part about research and what we as researchers do in this area is just like researchers in basic science, we publish. And so on the appropriateness work, we had 2 articles in the New England Journal, several articles in Medical Care and in JAMA. Went on as we studied the DRG-based prospective payment system and its impact nationally on quality, to have an entire issue in JAMA, the first one ever on quality, about how the payment decisions are made, about how hospitals are paid, how that influence what happens to patients in terms of their care and outcomes, and to try to think about how payment and how administrative structures influence what happens. And I know that's what a lot more of today's talk will be about. It's just a little bit about some of the research I do, but also about the research that many of the people here today do. So I look forward to, I guess, learning from each of you today and trying to see if we can build some bridges, because there's an incredible amount of knowledge and experience here about how to take UCLA and move forward in this area. Working with RAND, working with Kaiser, working with the larger UC system, and LA County and others. So thank you very much.
So, hi everyone, I'm Liz Engel. I am the Chief Strategy Officer in UC Health. I feel compelled to disclose that you all have bestowed upon me a degree that I don't have. I am a lawyer, not a doctor. But I'm going to change gears a little bit and talk about, at the high level, what's going on at a system level, to think about some of these issues, and hopefully offer some ideas to foster some conversation about how our office might provide some tools and resources to facilitate these efforts. So for those of you who don't know, UC Health is a small division within the UC Office of the President, and we, in essence, provide leadership and strategic direction to foster system-wide collaboration, and also to try to catalyze innovation within the UC Health enterprise. And in essence, we are looking for activities to undertake where the whole is greater than the sum of the parts, where acting at the system level is, or at the regional level, is beneficial to all players. Our office recently completed our division's first strategic plan, and to be clear, this is really a plan for our little division, not for the clinical enterprise, but I thought that sharing with you some of our key goals would be useful and relevant to this discussion. So first, one of our primary goals is around leveraging system-wide data to glean insights and optimize performance at the system level. A tool is going to, when he gets here, we'll talk more in depth about some of the activities already underway. But I'll give you a little bit of background and thinking as to how we arrived at this objective. So while there are, as everyone here well knows, robust analytics capabilities and activities at the campus level, we often don't have or use data at the system level to provide insights locally, to drive new insights across the system, to help our schools and medical centers do what we're already doing better, faster, and more economically, notably to facilitate scientific research, and also to help us determine what initiatives to prioritize and accelerate and where it makes sense to act as a system. From our office's vantage point, we've been looking at data largely from a siloed perspective, and at the system level, our use of data is ad hoc, and we use it to inform some projects and not others. And what we were looking for is a repeatable business process to leverage data quickly and accurately. As folks here know, Dr. Pfeffer and Dr. Buden and a couple of other core folks established the incredible UC Health Data Warehouse, but there hasn't been a devoted focus or resources or clear strategy for system-level use of this data. So in our plan, our proposed solution is to establish a center within UC Health to address these gaps and further develop the incredible potential of the UC Health Data Warehouse. And the center would have 4 main functions. One is building and maintaining the technical infrastructure and developing data analytics capabilities. But it would also include data governance and, most importantly, strategy and support and project management services to really advance internal activities as well as collaborations with third parties. So, I think it's important to note that this is really, the idea here is for this center not to have, a top-down strategy, but the role of our office, and you'll see this theme throughout, is really to convene and develop a strategy among experts at the campus level. So that's one goal, and it will relate directly to the second goal I wanted to talk to you about, which is establishing system-level quality improvement and population health management activities. So again, we are looking at each of the 5 medical centers, and their respective faculty practices are obviously responsible for managing populations of patients, and they are at different levels of competency to do so successfully. Here at UCLA, as evidenced by this discussion today, you all are leading the way in so many ways. At the system level, we are looking to compare standards of care, outcomes, and other data so that our medical centers and health plans can identify best practices within the system. And this would be with regard to making decisions about care management, and of course ensuring that we are providing patients the right level of care and in the most appropriate setting. So you all may be familiar with the work of CHQI, the Center for Health Quality and Innovation. The idea here is for this new function to build upon the efforts of CHQI, as well as multiple efforts around the campus, around the system already, to convene and conduct quality and population health management activities at the system level. But looking again from the 40,000-foot level from our vantage point, it was really our sense that additional leadership and clinical leadership and project management support could be required to identify and implement effective system-wide approaches. So what we're proposing to do is to establish some organizational infrastructure, clinical leadership, relevant expertise, and project management to enable UC providers and self-funded plans to develop and implement data-driven quality and population health management activities. So emphasizing again, as with the data function, the idea here is not to sit up in Oakland and come up with a strategy and implement it. This function will be very lean, and the goal is to convene experts such as those in this room, to convene groups of experts at the system level, to identify low-hanging fruit, identify the areas where we should be acting as a system. So both of these efforts are just getting off the ground. So I am so grateful to be here and learn more about what is happening here. And I hope that with this very high-level context, we can talk about, in these discussions, you will keep in mind where it might be beneficial to act as a system, and talk about and think about how the tools and resources, such as those I'm describing, the data warehouse and data analytics tools at the system level, and a system level convening quality/population health management function might facilitate your efforts.
Great. All right, thank you guys. So I'm just going to open with, I'll just have start with one question for the panelists. Anybody can answer, and then I think at that point, after that, we'll open the floor to questions from the audience. But I guess if I had to ask one question, it's really about getting at that meaning. What do we mean by value? And there are many definitions we've heard. Quality over cost model from Catherine and Cheryl as a broad conceptual model. Quality divided by costs. We've heard from Catherine and the RAND appropriateness criteria. It's actually separate from cost. It's the value is about clinical outcome and benefit to harm. So there are different ways of measuring value, and then it also depends on value to whom. Is it value to the patient? Is it value to the health system? Is it value to the society and the taxpayer? So there are different definitions depending on who your perspective is or what your perspective is. And if there are different definitions, is that okay? Because I don't think we'll ever come to one single all approaching. And I guess the question is really the tough one is, what do we do when these definitions conflict? And when value for the patient conflicts with value for society, and how do we sort of get around a problem like that?
So I think it's a great question. It's a really hard question, but I think we can do it. And I think we need both structure and we need agile flexibility. And what I mean by that is it reminds me a little bit about clinical practice. That is, we have a structure, we have a clinical model about how the body works, and given even all the limitations we have in clinical practice, there are certain things we know that make a difference. Some of them are scientifically validated. Sometimes they're experientially validated, as people talk about. But we have some sense about what matters. But we also know clinically that we need to adjust every decision, every way we're thinking about working with the patient to what do we see in front of us? So who do we see in front of us in terms of what the patient's needs are? And patients' needs are dynamic. They're not only is there a lot of heterogeneity in terms of what different patients need, but over time within patient, it's a dynamic set of needs. And so when we think about appropriateness or when we think about value, we have to recognize that we need to have this certain amount of flexibility because patients are different and what they need at different times is different. At the same time, if we don't build in a very robust, structured system, scientifically based about what we mean by structure and what we mean by process and how do we think about outcomes, I just think we'll keep spinning our wheels. So in summary, I think we need a robust structure that can handle the dynamic nature of patient and population needs.
John, your question had multiple questions inside it, so I don't know if I'm going to answer them all, but I do think you raise a number of really important issues, namely from whose perspective. I think at the end of the day, what the patient values is sort of their own individual outcomes. And I think as an industry, we're very short right now on our ability to measure outcomes that matter to patients. And even when I speak with clinicians, we did this project several years ago for the Commonwealth Fund and RWJ, trying to think about taking measures. So we had sort of this collection of lots of individual measures that were being applied, but with new payment models emerging, such as bundled payments, the idea was, we might be paying for episodes of care, and so how do we somehow or other compile these measures together to represent an episode? And as we looked across a number of conditions and we tried to map existing measures to an episode, it became painfully clear that we couldn't measure 90% of what's going on in an episode. And most importantly, we couldn't measure intermediate outcomes, and in some cases, we couldn't even measure whatever the ultimate outcome was. And the people hadn't really decided what that was. So I think that there's what I would call a lot of hard thinking to be done, methods work to try to advance this field of measurement to be focused on sort of this outcome that matters to patients and what clinicians should be focused on working toward. So I see that as an important gap area. And then I think kind of this issue of value and kind of what it means to the different stakeholders. And now I'm going to move into the space of health systems and the payers. I think the overriding concern right now is how to work toward more efficient production of healthcare and to try to flag all the possible, areas of inefficiencies in systems. And some of those are what I would call operational, some of them are structural, and some of them are the types of services that are provided that don't yield benefit to patients, but drive costs in the healthcare system. And I think that, again, we need to think about what are all the types of things we're trying to go after and what are the best mechanisms to not only measure them, but to address them. And I guess, again, when I am out there talking to systems right now, I'm doing this work in 4 states, and we have repeatedly asked systems to tell us what it means to be high performing. Very few of them are able to articulate that in a way that is measurable, that tells me they've thought hard about how they're working operationally to get there. So I think we, as a really smart group of people working in lots of different areas of research, can help provide some, what I call, structure to their thinking about this.
That's great. Thank you, guys. So I am going to open the floor, but since nobody's up, I'm going to ask another question.
Mics are on the side.
Mics are on the side, and but while we wait, we have all this intellectual firepower here, so I'm just excited to ask and just be selfish and just take it for myself. But so what I was going to ask was, with any intervention, when you're trying to improve value, there's trade-offs, there's opportunity costs, and there are unintended consequences that you may have not foreseen. And I mean, one of the foreseeable ones is when you try to reduce low-value care, you run the risk of reducing people who need care. You can reduce high-value care unintentionally. And so how do we make sure that we're thinking about the trade-offs, the opportunity costs, and the unintended consequences so that by intervening, we're actually not making things worse?
So I think that's a great question, and there's probably a lot of different ways of unpacking it. I think that when you're doing any kind of randomized trial, you're measuring the safety of what you're doing in an ongoing way, and going back to outcomes, that's something that can also help us ensure that when we're intervening, we're also not impairing the endpoint outcomes. I think the other part of that we haven't really talked about is outcomes as they relate to personal preferences and goals. And even worse than outcomes, it's much harder to understand what outcomes really matter to patients. And it may be the case that some patients have different preferences for outcomes than others, and understanding if you've harmed somebody with respect to what their preference is, say for longevity, as opposed to another person which may have a preference for having their pain managed. And that level of detail, it seems really challenging. And I think going to how you would manage this at an operational level, putting the data collection procedures in place, and making it something that's accessible for not just researchers, but actually practitioners, is definitely a challenge. And I would be very interested in how the people in this room might tackle those kinds of problems.
That's great. So thank you, Daniela. We have a question from the audience. Please just introduce yourself, where you're from.
Yeah, hi. Good morning. Michael Gould from Kaiser. So this is a really great day of activities, and thank you guys for kicking it off. I want to be a little bit provocative and challenge this notion that we don't know how to think about value. And from my perspective, it seems like we have a case of collective amnesia, or maybe even a little bit of PTSD. And Specifically, I'm referring to formal cost effectiveness analysis, which is a set of methods that's been around for 30, arguably 50 years. It's been standardized. Everyone knows that it's got limitations. It's not perfect. But it seems like we've taken a giant step backwards when people are introducing this idea of outcome over cost, and then don't take further steps to operationalize it when we already do have this formal methodology. So I wonder if people can, comment on that a little bit, and maybe even acknowledge some of the barriers to accepting that as a, I'm gratified because at least the ICER people are taking a step forward with the methodology. But now there are all kinds of competing frameworks, and I think some of it has just created confusion. So I'd love to hear others' take on that.
All right, I think I'm in the hot seat. So I think your question is a good one, and I do think that people have thought about using cost-effectiveness types of approaches to measuring this, but I think that it's not so easy to always do a cost-effective analysis, in part because you're not necessarily capturing all the relevant input costs, and trying to measure the effectiveness gets a little tricky. So while kind of there's a way of doing it, we don't necessarily have all the right measures to do it. So the question that I would put back to you, and I think this is what the industry as a whole is struggling with, is, how many different things do you have to measure? Like how much money are we going to spend on this measurement enterprise to try to move the dial in the direction we want? Because, I see the industry struggling with what's our ability to put into practice measuring patient outcomes. And that's a huge struggle. And what I keep hearing back from systems is, nobody pays us to do that. And, what's in it for us? And despite the fact we're all talking a good game of wanting to work toward better patient outcomes. I'm not sure I have a great answer for that. I think people have been, taking this very simplistic approach right now, which I'm not sure is the best one, to just say, okay, here's where you stand on total cost, here's where you stand on quality, and we're putting you in some quadrant. And somehow or other, we're going to weight these different dimensions and say that this entity gets, 5% more money than the one in the lower quadrant. So I guess the question is do we as an industry, and UC as a health system, Kaiser, USC, and on it goes, is that the way you want to be measured and valued as an organization? And so I think it's really incumbent upon the people, in this community in Southern California as well as nationally, to try to help advance smarter ways for people to assess the performance of the health system. And I don't think we're there yet.
Thanks, Cheryl. Just so we get to everybody's question, I'm just going to move on to the next question. Can you just tell me which one came first? I didn't. Okay, go for it. Just say your name and where you're from.
Hi, my name's Bean. I'm a hospitalist. Thank you so much for a very thoughtful discussion, and actually give me a lot of kind of thoughts and questions, and I'm trying to see if I can articulate in a kind of just focus on one question. So we know there are a lot of variations in healthcare, and there's specifically one slide earlier that struck me is our cognitive knowledge in medicine, in healthcare, has been growing almost like exponentially in the last few years. And there's this study showing there's 75 randomized clinical trials, 11 review articles every day, published every day. So it's almost impossible to any human being to be able to comprehend it and provide the most evidence-based care. And that's definitely something I struggle with every day when I take care of patients. So my question, and there's I think we're just surfacing the tip of the iceberg of personalized medicine, and realizing that the one-size-fits-all situation is not the kind of the way to practice medicine. So my question to all of you is, how do we think about providing the most value and reasonable and quality of care to patients in the era of personalized medicine?
So I'll just start with some, obviously different comments than these folks, but looking at the system level, and this is really what UC Health is trying to look at the system level. How do we take best practices, for those of you who have dug deep on certain practices, on certain measurements, and really found out what works from an outcomes perspective, from an efficiency perspective, and from a cost perspective? How can we identify those best practices across the campuses, share them, and then take these insights and into action and disseminate them broadly? So I think there is some value in, again, recognizing that my frame of reference is quite different than the others on the panel. The hope is to be able to expedite some of these activities by marshaling all the various efforts on the multiple campuses within UC. Great. Daniel?
Hi, I'm Daniel. I'm a primary care resident here. My question is revolving, I think Berwick and Don Berwick, former head of CMS and IHI, in 2015 said that he called for a 50% reduction in the amount of metrics that we use to measure our quality in medicine. I think that's only increased since that time, 3 years later. As we move towards value-based care, what policies or strategies are being employed to ensure that we are not overburdening our operational and clinical teams with more and more metrics so that we can continue to provide actual high-value care?
Well, I think that's one of the points of today's meeting. What I mean by that is we need collaboration across the clinicians, across administration, across the UC system, across all these organizations, so that we can line up this structure. So, on the one hand, I'm a big fan, and I know everyone else is here, is also of validity. But, how much is the right amount of validity, and what kind of validity, and how do we balance external validity or generalizability versus the internal validity versus the clinical validity? These are principles that I think we can agree upon. Here's a time when I think it's helpful to think about basic science and what we in this area of quality of care, quality improvement, and value science can learn from basic science, and that is, not only wasn't Rome built in a day, but the scientific method and the human genome exploration wasn't built even in a century. And this kind of work just takes a while, and I think having some understanding of that, and then kind of going back and forth between big picture and detail, and saying that's just part of the business, that's just part of what scientists do. And I think we would make a lot of progress if we recognize that's part of science.
Anybody else? Dr. Huffman?
Yeah, hi, I'm Jerry Huffman from UCLA. I appreciate the enormous complexity of this enterprise and how complicated and difficult it is even to define what we're trying to measure and our metrics, and trying to understand the science of it. And I don't want to make it more complicated, but I hope even at this early point, we will start to look at all of these things to consider another factor that I don't think we should be talking without thinking about. I like to think of undertreatment and overtreatment, or the absence of high-value care, of availability of high-value care for some segments of our population, and the presence of the over-treatment, the overuse of low-value care for other segments of our population, sort of as Siamese twins, tied together at the hips by a profit-driven healthcare system. And I would like everyone to start thinking about how, before we look at this larger issue in isolation, don't we have to be considering the drivers of these overtreatment and undertreatment? And can we even begin to discuss it in a larger world where there's fake news, and in a larger medical world of where a tremendous amount of what gets published is inaccurate and biased? Shouldn't we be, I hope we will be considering the drivers of this craziness at every point that we try to address it, and not pretend that this is just an isolated scientific endeavor outside of social context.
Hear, hear. Yeah, I mean, part of the work, so I love going inside organizations and talking to people and finding out sort of, so what do you think is happening to you, and what are you doing about it, and why are you doing what you're doing? And I think I have been struck, despite, so in the, what was it, late 1990s, pay for performance emerged on the scene. And I started looking at pay for performance experiments. And, you know, the Secretary of Health and Human Services said she was going to up the ante in Medicare. And everybody's been sort of pushing this dial. But when you go inside health systems and you really understand how payment works, incentives are just a tiny fraction. I mean, the real incentive is pay to do more. And I think that is the context that you are talking about. And so despite the fact that people like me are trying to say, oh, I'm going to study some pay for performance program and figure out whether it worked, you know, the overwhelming tsunami in the room is pay to do more. Organizations are, so I see this in my health systems research, which is they're gobbling up players in their local communities to try to become bigger entities, to get bigger pieces of the pie and preserve the portion of the pie they have. And this is driving a huge amount of behavior in this community, and we cannot ignore it. So I agree.
So I would agree, great points, but we do have an opportunity now as federal agencies have been starting to incentivize not just personal health or one-on-one, but population health. And when we think about population health, I think that addresses what Dr. Huffman was talking about, which is trying to be aware of how do we take care of vulnerable people and not just people who can pay a lot. I want to call to attention, for those of you who haven't seen it, a JAMA article that just came out this week, Approach for Achieving Effective Care for High-Need Patients. It's a really terrific article from the National Academy of Science, or National Academy of Medicine. And what they did is they identified 6 groups that are very, very costly, the 6 most costly healthcare groups of patients. But in addition to the importance of that, they did 2 other great things. And one of them is they said, the way in which each of these 6 groups is costly differs. Vulnerable elderly are costly because they spend a lot of time in a nursing home or in a hospital. Another group, the people who have congenital conditions and then survive, they're costly because they spend a lot of money on medications. The point is that they included recognition of these very diverse groups and identified where they're costly, which provides the foundation for a mechanism of how we can address these costs. But the other thing they did that I thought was super important is they said, in addition to what we're telling you about these 6 clinically based groups, each of which has a different pattern of costs, and by clinical they looked at the morbid disease, the comorbid disease, and functional impairment. That's how they define these 6 groups. They also said you can't really understand how to improve the system without taking account of mental health problems and social determinants of health uniquely for each of these conditions. And so I thought it was a great paradigm that there's this morbidity, comorbidity, functional impairments, that there's social determinants of health, and then there's mental health issues. And I think in order to address the topic that Dr. Huffman was saying and Cheryl was saying is we need to figure out how we're going to get structure and cost issues and quality to think about all those three topics.
Thanks, Catherine.
One footnote on that, just, building, nowhere is that more true than caring for our Medi-Cal population. And in terms of incentives, obviously that is a place where we are, very much at each campus not covering the costs of care for those patients. We lose money. So there, dealing with all these factors that you were just talking about, we really have an incentive to look at that population and manage it, something also that we are trying to tackle at the system level.
Thanks. Sam?
Yeah. Hi, Sam Skutsky from UCLA. This is a great discussion. I wanted to throw out an idea, not to substitute, because everything has been great that's been discussed. But to me, one of the issues is to provide high-value care, whatever that means. You do have to have some time to think about what you're doing. So I think one of the issues, and I'm not sure how it is addressed, is how to make it so the provider has enough time, in the office environment to make good decisions or to work with the patient on shared decision making. And that has to do with things, is there really a medical home approach, teamwork in the office? Is that really well done? Are there really medical neighborhood structures so that the primary care and the relevant specialties are working together and have agreed upon how to care for patients? And then finally, in the EMR realm, which is a fantastic tool, is it really organized in a way so that every click is a value-added click? And I don't know if enough time has been spent on making the EMR tool something that naturally collects the patient-reported outcomes that we want, naturally collects the kind of clinical material that Cheryl was talking about. I think it's an untapped resource that could be changed. We used to talk about the fact that the administrative claims data sets were never intended for quality work. I mean, everyone uses them to measure quality, but what are they really optimized for? They're optimized to pay the doctors and the hospitals. So it's a payment mechanism. It has nothing to do with quality. So I think the same is the issue with the EMR, that it's optimized for certain business processes. I don't really know if it's really been optimized for quality improvement work or value work.
Thanks, Sam. So we're going to have one person on the panel answer that, and then we'll go to our final question on the right.
So I'll answer it because I've done a little bit of research in health IT safety with some of my colleagues at RAND, and it's not only that they're not optimized for delivering care well, there's also some real risks in the way that health IT is set up to, by default, deliver the worst care. And I was listening to the radio on the way here, and somebody was literally talking about your point, and somebody said, oh, you can get your bill out in 3 clicks, but it takes at least 10 to 12 clicks to register an allergy. So you can see how just the default settings around these tools that are around us can actually be impairing the way that we are, might be delivering care. And you made some other points that I think are great, but I don't want to use up all the time on that.
Thank you. Last question.
Paul Vespa from UCLA. I'm fascinated by the concept of the behavioral economics. You've talked about high variability and perhaps lack of data or lack of understanding of the available quality data. I was involved in a quality metrics program from the American Academy of Neurology last year, and very high standards. And a quality metrics document was created. There's going to be variability on this. How does one move towards, or how does one apply behavioral economics to sort of drive this, or behavioral nudges to sort of drive compliance or decrease variability? And is that something that we need more research on, or is that something that we're ready to implement, a little of both?
I think Danielle is probably the best person in the room to answer that question.
So I think there's a lot more research to be done, and we've done some initial studies on it, and the results have been really fascinating, especially in terms of what behavioral interventions stick versus which ones don't stick. And the kind of things that are built into your EHR, they can create these nudges that will nudge you one way or the other, but they don't stick as well as things that leverage culture and social psychology and the professional identity that I think is part of what has to be created with our value-based systems as well. And hopefully collaboratives like this will be able to form the foundations for this kind of culture.
Thank you, everybody. It was a great discussion.